This is Mrs. Daniel. Today we're going to cover somatoform, factitious, and dissociative disorders. This information can be found in Chapter 29 of your Townsend 8th edition textbook, which begins on page 581. By the time you have finished this lecture, you, the student, should be able to provide safe and effective mental health care based on sound nursing judgment and also make decisions for the consumer, the patients, or clients as individuals in conjunction with their families, as well as groups experiencing somatoform, factitious, and dissociative disorders. This is including, but not limited to, assessment and observation of a client affected by these disorders, awareness of DSM and NANDA diagnostic categories and criteria, as well as understanding the nurse's role in the care of clients affected by the above-mentioned disorders. This includes therapeutic communication and development of therapeutic relationships, recognition, prevention, and management of complications, as well as specific therapeutic treatment modalities associated with somatoform, factitious, The first category that we will discuss is somatoform disorders. Somatoform disorders are involuntary physical complaints or symptoms without any sort of organic pathology or any sort of identifiable physiologic bases. Usually they involve psychological factors or nonspecific conflicts. What you'll notice with this particular disorder is that there is some level of dysfunction with the client in their physical self-awareness. All of your somatoform disorder sufferers are obsessively interested in bodily processes and diseases. All their attention is focused on the discomfort that they're experiencing, but this is all usually the result of some underlying anxiety. But again, it is very important to note that in somatoform disorders, these symptoms are not intentional or under the conscious control of the patient, such as malingering behaviors or factitious disorders, which we'll get into later. Soma is actually the Greek word for body. Somatization can be described as the expression of psychological stress via physical symptoms, hence the term somatoform disorders. So anytime you see somatoform disorders in regards to exam questions or in any sort of content, keep in mind that this is involuntary expressions of anxiety that manifests itself as physical symptoms. Involuntary would be the key word here. Here I have listed some predisposing factors for those affected with somatoform disorders. You'll notice that I have a variety of things listed here, but the two that I'm going to call to your attention the most is family dynamics and learning theory. In regards to family dynamics, when you're dealing with dysfunctional families, usually when a child becomes ill, the focus shifts from the open conflict to the child's illness and leaves unresolved underlying issues that the family is unable to confront openly. So in a lot of ways, it reinforces that child's ill behavior. You'll see a lot if someone feigns a lot of illness, it kind of shifts the attention to something different and it helps to relieve some of that tension and that stress. Somatization also brings some stability to the family and positive reinforcement to the child. Again, if they're getting the desired behaviors that they like, then they're going to continue on in dealing or exhibiting that behavior. Same thing applies in regards to the learning theory. Somatic complaints are often reinforced when the sick person learns that he or she may experience primary gain or secondary gain. These particular terms are very, very important, and I can almost guarantee that you're going to see them again. So it's very important that you know these. So when you're dealing with primary gain, there is removal of the initial emotional conflict or immediate relief for the anxiety or the immediate stressor. It helps them to avoid stressful obligations, postpone unwelcome challenges, or they may even be excused from unwanted duties. So, for example, if a person starts to feign a certain illness and they have a presentation tomorrow, by feigning that illness, they don't have to deal with that stress of that presentation. That would be the primary gain. So, primary gain is immediate relief from the stressful situation or scenario. Secondary gain is actually the benefits derived from the symptoms alone. These are just additional things that reinforce that sort of behavior. The client may become the focus of attention because of the illness, or they may even receive other benefits. A lot of times with somatoform disorders, what you'll see is the family is exhibiting behaviors that reinforce the somatization disorders. So, for example, if a person is feigning to be ill, again, this is an unintentional effort. They receive lots of attention, lots of nurturing. They may receive help at home, cleaning or cooking, all those different behaviors. If they have somebody there to take care of them and things like that, it enables them to continue on with that sort of behavior. Again, it's very, very important for you to know those. We'll get into some different types of somatoform disorders. Usually, when you're dealing with illness anxiety disorder, or there's an issue where the past experience with any serious or life-threatening physical illness, or a lot of times is the main influence. So when you're talking about learning theory, that's something that may be a predisposing factor, especially illness anxiety disorder translates into a hypochondriac. So if an individual may have seen a relative that deals with cancer, or say their father died of a cardiac arrest, they may be a little hyper vigilant and misinterpret minor cues for fear of also succumbing to that same illness. So the learning theory also works in that regard as well. But the two that you definitely need to be aware of is primary gain, which is removing that patient or releasing them of the obligation from that immediate stress or that immediately anxious incident. And then you have secondary gain. These are all the other benefits that come secondary to the actual illness. So cooking, cleaning, help, attention, all the above would fall under secondary gain. So the first disorder that we're going to cover within this category is going to be called somatic symptom disorder, and it's also known as somatization disorder. Be very, very careful in this particular section when dealing with some of the terminology, because it sounds very similar to the overall category that we're talking about. But this is one specific subgroup or subset of disorders associated with the overall big umbrella of somatoform disorders. So in regards to test taking and reading and going through this information, be careful about the wording on some of these things. But somatization disorder is basically a syndrome of multiple somatic complaints that cannot be explained, again, by any sort of pathology or organic findings. And it's usually associated with some sort of psychological trauma or issues or distress. All right. What you typically notice is that multiple symptoms are usually including, but not limited to, dizziness, shortness of pain, palpitations, constipation, bloating, nausea, dysphagia, and these are just to name a few. Pain is almost always involved, but is not the hallmark symptom. So what you'll have with somatization disorder are multiple vague symptoms or complaints that extend above multiple or beyond multiple body systems. So they may have some cardiac issues, some breathing issues. They may complain of some GI symptomology, overall pain. Um, they're kind of all over the place. And again, the key here is that it cannot be explained by any diagnostic or pathological disease process. With this disorder, usually the onset of symptoms begins before the age of 30. Usually you start to notice that people are dealing with this sort of thing in their late teenage years. And like I said, the symptoms span across multiple body systems. This particular disorder results in impaired social and occupational functioning. And what you also run into is the risk for the patient seeking excessive medical help. So a lot of doctor shopping happening with this particular subcategory. And because of that, clients are going to, of course, seek or receive care from multiple physicians. And sometimes this is at one time or concurrently. So for that, we're worried about um, risk for abuse of medications or over medicating, especially in regards to analgesic or anxiolytic medications. So dependence is one of the risk factors that we do worry about with this particular disorder. The disorder is chronic and it does have some underlying anxiety and depression issues. Suicidal ideation is also very common because the client actually starts to feel like they're going crazy and nobody believes their complaints. But again, it's a manifestation of underlying issues that they kind of need to get to. The doctor shopping usually happens because they're not actually getting the answers that they need. So they move on to the next doctor and they move on and they continue through the ranks until they find somebody that is going to reinforce what they're actually verbalizing or feeling or what they think that they're feeling. The next disorder that we're going to talk about is illness anxiety disorder. Illness anxiety disorder is formally known as hypochondriasis, and it's an unrealistic or inaccurate interpretation of physical symptoms or sensations, which leads the person to become obsessive or fearful of having a serious disease. Usually, the difference that is easy to pick up on between this one and somatization disorder is that you have the documented proof that there is no sort of disease process happening. However, the preoccupation with the symptoms is going to persist despite any sort of medical evaluation. Approximately 1 out of the 20 people who seek medical attention will suffer from this disorder. It usually happens more with females than males. But again, like I said, with this disorder, the clients misinterpret innocent physical sensations as being indicative of a serious illness. A lot of times when they are seen medically, they cannot be swayed or reassured by any confirmation of negative diagnostic findings. So even if you were to show them diagnostic lab work or results and it said it was negative, they're still not digesting that information and they still obsess over whatever their complaint is. This category is also known for doctor shopping, and they usually go through great lengths to seek medical care. And they're always very frustrated because, again, they're not getting the confirmation that they need in regards to how they actually feel. They are highly likely to refuse psychiatric referrals because they don't see the connection between their obsession over their physical symptoms in conjunction with any sort of underlying depression or anxiety issues. Usually you have behavior responses, even to the slightest changes in feeling or sensation is going to be very unrealistic, very exaggerated. They do experience quite a bit of anxiety and depression, like I said, as underlying. But again, keeping with some of the things we've talked about in recent weeks, they also have some obsessive compulsive traits that are also going to accompany the disorder. So with these people, again, unrealistic or inaccurate interpretation of physical symptoms. These are people who may get a bug bite and they may feel like they have cancer. It always is something very exaggerated, unrealistic. Maybe they haven't gone to the bathroom, they're a little constipated. Oh, I have stomach cancer or something like that. And these are very exaggerated examples that I'm giving you, but this is kind of the theme or the way that they kind of think. And again, sometimes it's due to past experiences with some sort of family member or a friend dying from a death. You just never know. So it's our job as the nurses to get to those underlying issues to figure out what caused them to obsess over a particular disease process or their physical symptoms so much. The next disease process or disorder that I want to talk about is body dysmorphic disorder. Now, it used to be that all of these disorders that we're talking about were lumped into one big category in dealing with anxiety related disorders, but your book kind of structures this differently. This is one section that it remains in the anxiety disorders chapter of your book. So for this particular disorder, you are going to have to refer back to chapter 27 in your Townsend book on page 537. So, body dysmorphic disorder is when a client has some sort of preoccupation with some imagined defect in appearance. But the preoccupation is so much so that the client usually has some social and occupational dysfunction or a significant amount of stress. And that usually manifests itself with obsessive thinking and compulsive behavior like checking the mirror or camouflaging and things of that nature. Again, I mentioned that this is found in chapter 27 of your Townsend book, which is the chapter about anxiety, obsessive, compulsive, and related disorders. Some of the common imagined defects that you have include flaws of the face or head, such as wrinkles, scars, shapes of the nose, facial asymmetry. Those are just some of the common ones specific to that general area. They may also feel like they have flaws related to their ears, eyes, mouth, teeth. Usually, we hear about body dysmorphia a lot when talking about bulimia or anorexia, but it is a separate diagnosis from those things. Body dysmorphic disorder can perpetuate those other diagnoses or issues, but it is a separate thing in the DSM criteria. In some instances, if there is an actual defect present, the client's perception of that defect is very unrealistic or exaggerated. So, say they may have had an incident when they were a child and they may have a scratch on their face less than half an inch. When they look in that mirror, they may see that that scar is all over or across their entire face, and they feel like it's more exaggerated and more of a problem than it actually is perceived to be. When you're dealing with these clients, some of the things that you may see in regards to assessment, when you sit down and actually do say an admission history on the client, you may see a very extensive medical or surgical history, and it may reflect numerous visits to plastic surgeons, dermatologists, etc., because this is all in an effort to correct some sort of imagined defect. If you guys are not familiar, Dr. Phil has done several specials on body dysmorphic disorder, but one of the bigger ones he's done is about the human Ken doll. If you ever have a chance to Google the human Ken doll, this is a guy who's had over 100 surgeries in an effort to look like a doll, essentially. But ultimately, it's some underlying issues with body dysmorphia, and that's like a classic textbook example if you need something to kind of keep in mind when you're dealing with this sort of disorder. Conversion disorder is another disorder that falls under the big umbrella of somatoform disorders. Conversion disorder is defined as some sort of loss or change in body function, again, that cannot be explained by any medical disorder or any pathophysiological mechanism. What you'll find that differentiates conversion disorder from something like somatization disorder is that with conversion disorder, the symptoms usually affect voluntary sensory-motor function, and usually they are suggestive of some sort of neurological disease process. So I have some examples here of different symptomology that you may see associated with conversion disorder, but if you can think conversion disorder, neurologic presentation, that's the best way to go about it. Some examples I have listed here are paralysis, aphonia, difficulty swallowing, hearing or vision issues, seizures or pseudo seizures, anosmia or inability to smell. One of the bigger ones that you see quite a bit in psych as a whole is pseudocyesis. This is known as false pregnancy. Now, false pregnancy can also be a delusion, but it also falls under conversion disorder. So I would definitely know that term just because you're subject to see it again at some point. Again, conversion disorder is characterized by deficits that usually affect voluntary motor or sensory functions, which you can see based off of the examples here. The disorder is itself is still an involuntary and unconscious effort. So do not be confused by some of the terms that we have here. Don't get that confused. It's still a very unconscious suppression or um, way of expressing underlying anxiety. The illness is usually suspected, it's very rare, but if it does happen, it's suspected if the onset is usually precipitated or preceded by some sort of major internal conflict or stressor or trauma. A lot of your psychiatrists or your psychotherapists believe that the symptoms that are associated with conversion disorder are very symbolic of psychological conflicts. So, for example, in some cases, a person that's experiencing vomiting may represent revulsion or disgust. An individual that all of a sudden has vision issues or blindness, that may represent some inability to accept the witnessing of some sort of traumatic event. See a conversion disorder happening a lot among people that are under a significant amount of stress. I saw a Dr. Phil special, and again, I'm not sure how true it is, but there was an individual that was supposed to go to college, and all of a sudden they started having these issues with their legs, and they were paralyzed. There have also been incidences of conversion disorder very closely associated with those that have been in any sort of war or combat and things like that. One of the things that you'll notice about conversion disorder that seems a little bit different from some of the other disorders that we've talked about so far is that, again, they do not intentionally produce the symptoms, but one phenomena that they gain or that they exhibit is what we call labile indifference. And this is when the individual is very complacent or they show lack of concern over their physical symptoms that are actually happening. So this is very different than your hypochondriacs or your illness anxiety or your somatization where the person is obsessing over these physical symptoms. The person feels these symptoms or they're displaying the symptoms, but they don't get any other sort of gain from them like the other ones, other than psychological or immediate release of the underlying stressors. So you'll see labile indifference with this is very specific to this disorder. And again, it's just basically complacency with these symptoms. They don't seem worried about the fact that they can't use their arm or they can't walk, or they don't seem to be as concerned as other people may be around them. On this particular slide, I'm not talking about any specific disorders, but I did want to bring to your attention the fact that psychological factors knowingly affect medical conditions. And this is something that you guys may have already seen before in dealing with other patients on different floors in the hospital. And it's also kind of something that we touched on when we talked about stress and coping. So, psychological or behavioral issues or factors can be implicated in the development or exacerbation or even delayed recovery from a medical condition. So, if you have a patient that's been hospitalized and they've got diabetes, a lot of times if they're under a significant amount of familiar stress, or even if somebody's hospitalized with cardiac issues, if they have a lot of outside stressors or unresolved anxiety or conflicts, it starts to manifest itself in their recovery of their physical state. All right. There's also evidence that general medical conditions can be precipitated by or can be perpetuated by psychological or behavioral circumstances. So it's very important, and this is just here to help you guys realize that they kind of feed off of each other. So it's kind of trying to figure out which came first, the chicken or the egg. These are factors that feed off of each other, and it's more of a cyclical thing. So a lot of times, psychological issues are going to manifest itself in physical well-being, but with these particular individuals, it's just gone overboard or to the extreme opposite end of the spectrum. So we've covered somatoform disorders. The next thing that we're going to talk about is factitious disorder. Now, your book doesn't go into great detail because factitious disorder is very simplistic as far as its understanding what it is, what the motive is, so on and so forth. So there's only one slide that you need to know, but it sounds very, very similar to somatoform disorders, but there are some key characteristics that you need to be aware of. So, factitious disorders involve some sort of conscious, intentional feigning of physical and or psychological symptoms. This is formerly known as Munchausen syndrome. And when I say Munchausen syndrome, you guys probably know what I'm talking about. With this disorder, the motive is to receive some sort of emotional care and support, and it's usually associated with the individual liking to be in the role of the patient or the victim. Now, the thing that you have to be careful with this disorder is that not only can it affect, one individual, but it can also be imposed on another person under the care of a perpetrator. This is actually known as factitious disorder by proxy, which was formerly known as Munchausen's syndrome by proxy. The key here is the by proxy. So when the disorder or the symptoms are being imposed on the individual and is conscious and intentional, then that's just regular old factitious disorder. When the individual is trying to make someone else sick in order to receive that attention, that's when it's a by proxy disorder. Again, the key thing to remember here is that the behaviors are deliberate and intentional. What you find happening here, and I mentioned Dr. Phil a lot, but he has really, really good blurbs on YouTube if you ever have time to go and look at some of them. What you'll find is that if individuals do have a legitimate medical issue, they may aggravate existing symptoms, induce new ones, or maybe even inflict painful injuries on themselves. Again, all in an effort to receive emotional care and support. Dr. Phil actually had an episode where there was these children, they're very concerned about their mother and her issues with factitious disorder, and she was actually injecting herself with dirty, contaminated water, and she consistently was getting ill and getting admitted to the hospital, but she liked that attention from being in that sick role. Like I said, I can't say it enough. Often here with this disorder, the behaviors are deliberate. Um, the diagnosis is rare, and it's often going to coincide with borderline personality disorder, which you guys can probably easily relate because remember, your borderline personality disorders, they like to have that attention as well. They like to be a rescue response. They love for somebody to come save me, come take care of me, so on and so forth. A lot of times when you deal with factitious disorder by proxy, you're dealing with individuals who are imposing illnesses or injuries on an elderly individual or on a child. Lots of cases you'll see it with the child. So you'll have parents come in and these kids are sick and you can't really figure out what the underlying issue is, but that parent gets that attention. Oh, poor mom, she has to deal with the sick kid, so on and so forth. So that reinforces their behavior. And there are a couple of individuals that you can think of. If you have time, I'm going to go over them with you to look up their stories. It really, really resonates with actually what factitious disorder by proxy is. So the first case that we're going to talk about is Beverly Allett. This is Beverley, Allitt, Allitt. This particular person was she was a nurse in the UK, and she actually injected infants with lethal doses of insulin in order to turn around and try and save them in front of their families, and all this was in an attempt to be seen as a superhero and get that emotional support. She actually went on to kill several of those infants, but a lot of them said the parent would walk out of the room. She would secretly inject that infant, and somehow, all the time, whenever an infant was coding or had any sort of issues, she was right there and able to jump in and save them, and she received all that praise and recognition. Again, that was the positive reinforcement that she needed to continue on in that behavior. Some other notable cases, Kathy Bush. She gained public sympathy for the plight of her daughter, Jennifer, who by the age of 8 had undergone 40 surgeries, and she had spent over 640 days in hospitals for GI disorders. The acclaim actually led for the First Lady Hillary Clinton to visit the family. But in 1996, she was arrested and charged with child abuse and Medicaid fraud. And she was accused of sabotaging Jennifer's medical equipment and drugs to agitate and prolong her GI symptoms that she was being hospitalized for. What we found with this particular case is what confirmed that it was factitious disorder by proxy is that once Jennifer was moved into foster care, she quickly regained her health. The prosecutors that were in charge of the case, they actually claimed that she was driven. Kathy, the mom, was driven by Munchausen syndrome by proxy, and of course, she was convicted. She only served a 5-year sentence. She actually ended up serving 3 out of the 5 years. And she actually was able to get back in contact with her daughter. But this is some of the extreme cases that people will go through to try to elicit that support. A more recent case that you guys may be familiar with because it was heavily publicized was Lacey Spears, Lacey Spears, Spears. This happened in New York. She was charged with second-degree murder and first-degree manslaughter because she allegedly fed her son dangerous amounts of salt. After she researched on the internet about its effects, she fed it to him through his G tube, and she actually ended up killing him. And her actions, they found, were reinforced or motivated by the sympathy that she was gaining or the attention that she was gaining on Facebook and Twitter and blogs just from having this very, very, very super ill child. So factitious disorder is a very, very serious disorder. If you ever have time to look up about it and read about some of the real life stories that have actually come about, it's very interesting to look into. But the thing here that you need to remember is it's conscious, it's intentional. This is going to be very, very important when we get into the assessment phases of these different disorders, which we're going to talk about next. So as I just mentioned, we've already gone over somatoform disorders, which includes multiple disorders: conversion, body dysmorphic, illness, anxiety, somatization, and we also touched on factitious disorder. So now we're going to take a break from talking about specific disorders and get into how to apply the nursing process to this particular category. So just like any other nursing process oriented deal, we're going to start with assessment, which is the biggest component. Assessment is going to be really, really key here when you're talking about differentiating between all these different disorders that we've covered so far. So your assessment data is going to begin with data collection regarding to all the following bullets that I have listed here. It is important to recognize that although we assume that these complaints are somatic, the key here that we want to make sure we pick up on before we move any further is to rule out any sort of organic pathology. So once we've done that, we're going to move on and start getting into detail about the symptoms and the unmet needs that the client is experiencing. And what I mean by this is, when you're talking about symptoms, we want to know the nature of the symptoms, location, onset, character, duration. Sounds very similar to what you would ask if somebody was dealing with pain, nausea, what makes it worse, what makes it better, what's been going on. Unmet needs, you want to assess if the patient is able to meet their own basic needs. All right. When you're getting into voluntary control of symptoms, this again is key because during assessment, if the patient is exhibiting symptoms that are not under voluntary control, that immediately is going to rule out factitious disorder, and vice versa. If the client is exhibiting symptoms that seem to be under their voluntary conscious control, then we know we're dealing with factitious disorder instead of somatization. So it's very, very important to determine if the symptoms are under the patient's voluntary control. All right. Remember, somatoform disorders, not under the patient's involuntary control. They are unable to see the relationship between their symptoms and their interpersonal conflicts or anxiety. The next thing you want to look at is primary and secondary gains. You want to try to identify the gains a patient may be receiving from those symptoms alone. Remember that although the symptoms are an unconscious effort, gains may positively reinforce those behaviors. This makes giving up the symptoms that much more difficult. So you definitely want to pick up on those things because that's something that you're going to have to work on later down the line. In regards to cognitive style, this may assist in differentiating between somatoform disorders such as hypochondriasis or illness anxiety and somatization, because sometimes with your hypochondriacs, it's more of an issue of understanding of disease processes that causes them to obsess over certain physical symptoms. There's some knowledge deficit there. You want to make sure you're assessing their ability to communicate their feelings and emotional needs. Due to the prolonged history of ineffective communication of needs, such as childhood or even in adulthood, the individual may be using that, again, somatization, as a dominant means of expressing communication or internalizing any conflict. And then, of course, because of the nature of these diseases, we also want to assess for dependence or medications, doctor shopping, all the above. Individuals with somatoform disorder usually become dependent on anxiety medications and pain relievers, also maybe some sleep medications. So assess the type and the amount of medications being used. Here we have listed some common nursing diagnoses related to somatoform disorders. We have here ineffective coping, knowledge deficit, chronic pain, fear, disturbed sensory perception, self-care deficit. Some other nursing diagnoses that you may also want to include that may not be listed here are anxiety, impaired judgment, ineffective role performance, and powerlessness. It's very important for you to know what kind of problems you're going to be dealing with, nursing related or nursing diagnoses, so that when it comes to the planning phase, you know how to prioritize your time and what kind of interventions you're going to expect to deal with. When we get to outcomes criteria, the ultimate goal at the end of all of these nursing diagnoses is to have the client live as normal a life as possible. Again, focusing on outcome criteria, you want to make sure that the patient is able to, at the end of all this, live as normal a life as possible. So at the end of their treatment, some of the outcome criteria that you'll have is that the patient will be able to articulate their feelings of whatever origination, anger, shame, guilt, remorse, or anxiety. Remember, these are those underlying or internal conflicts that the client is dealing with that caused this situation to come to a head in the first place. You want to also be sure that the patient is able to resume performance of work role behaviors or assume their normal roles in their lifestyle. You want to help them identify their ineffective coping patterns. Again, this is an effort to redirect or rewire them so that they can respond to certain stressful situations or conflict appropriately. Most of all, you want to help them interpret their bodily sensations rationally. You want to help them understand that if they do have some symptoms that are going on, it's not anything that's as exaggerated as they may feel like it is. And a hope that we have with this particular group of clients is that over time they have a decrease in their physical complaints and they start to focus more on the underlying issues. So what you should see is a decrease trending downward in terms of the amount of time that they spend obsessing or complaining about physical symptoms. Some other things that are not listed here that may also fall under some outcome criteria. You want to make sure the client does not isolate themselves. Remember that anxiety and depression is one of those underlying issues. And of course, when you add isolation into the picture, you're dealing with risk for suicide and things, self-injurious behavior, so on and so forth. You want to make sure that they're able to discuss different aspects of their internal conflicts and figure out ways to deal with any sort of problem solving or conflicting obligations or issues. You want to make sure that they're able to look for the value and importance in things in life and help for them to engage in other activities that would take their attention off of worrying or obsessing over any sort of physical complaints that they might be dealing with. Again, one of the other bigger things that we're looking for is for them over time to have a decrease in the frequency in the time that they stew over obsessive physical complaints. We hope to see a decrease in that as they get better. More importantly for you guys to understand is specific nursing interventions or plans or things that you will implement on your end in order to facilitate this client actually improving their behaviors. So I have listed here a couple of nursing interventions. The first one that we have here is set communication guidelines. This is going to be really important when you're dealing with these clients. When a patient complains of symptoms, you want to take the complaint seriously, but you do not want to reinforce somatic complaints after they have been investigated and any sort of organic pathology has been ruled out. So it's perfectly fine if you address it initially, but once it has been ruled out that there's no actual issue, then you want to make sure that you don't continue to harp over it like the patient wants you to. You want to make sure that you offer explanations and support during diagnostic testing. Remember, knowledge deficit is one of the bigger problems that you're dealing with here, and not knowing certain things about procedures or diagnostic testing can facilitate increased anxiety and, again, reinforce those behaviors. So the more that you explain, the more knowledge that you impart, the less they have to worry about certain things. You always want to try to shift after you've ruled out any sort of major issue or any organic pathology. You want to shift the somatic complaints to feelings and more neutral topics. Let's talk about some of the underlying issues that you may have that may be causing your stomach to feel upset. Maybe it's anxiety. Maybe you've got something important coming up, things of that nature. You want to help them find the connection between the two. And then you always, of course, want to use a matter of fact approach. In regards to health teaching and promotion, again, continue to use a matter of fact approach and do not enable those behaviors. Allow the client to engage in the highest level of self care to which they are capable. This is very, very important for those clients that are experiencing those gains, specifically secondary gains. So you want to make sure that you're reinforcing independence. You don't want to enable them any further. Again, when you start to reinforce secondary gains, it gives them more of a reason to continue on with exhibiting those symptoms. So you want to cut that off. Do not allow the client to use symptoms as a manipulative tool to avoid any sort of participation in therapeutic activities. So an example I have here in regards to setting limits and encouraging independence. If you have a client that is experiencing conversion disorder, which result or manifests itself as paralysis of the left arm, you want to set expectations for the client to still provide self-care and eat and groom using the other arm. Just because that arm, in their opinion, is not working does not mean that they cannot care for themselves. Case management is another thing that we don't talk about too often, but it is really helpful in regards to these disorders. It may lessen anxiety with the patient and reduce healthcare costs associated with doctor shopping if you get case management involved. And usually, what it's able to do is help regulate doctor's appointments, help circumvent unnecessary diagnostic interventions. So, together, the client and the case manager can come up with a mutual plan. Well, I understand that you like to go to the doctor once a week. Let's set regular, short, brief appointments with your doctor on a monthly basis, or if it needs to be on a weekly basis, that's fine if you're dealing with a really severe client. But eventually, you want to start to pull back and decrease the frequency of those amounts of appointments. So it could be, again, setting up monthly appointments where the patient can just come in and talk about their complaints, and then they get the education that they need. But it's not them constantly seeking out help. Psychotherapy is listed under one of the major treatment modalities for somatoform disorders, and this is including individual and group therapy. Of course, it's going to include ruling out any sort of organic pathology. That's the primary thing here. But the overall goal of psychotherapy is to encourage the client to develop healthy and adaptive behaviors and encourage them to move past the somatic disorders in order to manage their lives and lead a normal life in the most effective way. Behavior therapy is more successful in instances where second gains are evident, just like we talked about. It really involves working with the family who may be enabling or perpetuating the symptoms. So it may be more of a collective effort that needs to happen. So what happens is the family is rewarding that sort of behavior, and that, like I said, it reinforces that client's symptomology. What it also involves is shifting the focus from more of independence and passivity to self-sufficiency, autonomy, independence. Those are the words that we want to be focusing on. Psychopharmacology is used here. On occasion, you will see clients with these disorders. If they have severe panic disorders or anxiety, you may see them actually treated with anti-anxiety medications. But again, with this particular group of clients, we're using pharmacology with caution because of the doctor shopping and things of that nature. It's very, very possible, or there's an increased risk for dependency issues, especially with benzodiazepines and opiates and pain medications. So you really want to make sure that in regards to psychopharmacology, you guys are treading lightly, not that you prescribe it, but it's also going to be up to you as the nurse to make sure that you're doing an adequate assessment and figuring out what the client is actually on at the time of admission or whenever you encounter them. Next, we're going to move on to talk about dissociative disorders. Dissociative disorders are derived in response to some sort of stress or anxiety, which results in an alteration of consciousness, memory, and identity. So everyone dissociates to some extent. How many of you have driven home and once you get home, you can't really recall how you got there, which way you took, if you actually ran a red light or what have you? Your brain was just kind of on autopilot. This is typically a very mild example of what dissociation actually is. So when you deal with dissociative disorders, again, you're dealing with some significant impaired functions of consciousness, memory, and identity. Those are the three components that usually you'll see some sort of disturbance in. Keywords here are the clients are using inappropriate defense mechanisms to deal with very stressful or traumatic events. So the two defense mechanisms that they're using inappropriately are repression and dissociation. Those are two of the common defense mechanisms that you're going to see that's a theme through all these disorders that we talk about. They're repressing some sort of traumatic event or stressor, which causes them to dissociate and experience these particular disorders. So here we have listed some predisposing factors for dissociative disorders. Two of the bigger ones that you're really going to be concerned with is neurobiological and then, of course, psychological trauma. Dissociative amnesia has shown to be related to some sort of neurophysiological dysfunction, such as with head injuries and things like that. But one of the bigger culprits for a lot of these disorders is some sort of traumatic experience that seems to overwhelm the individual's personal ability to cope. And so, in that regard, they repress it and again, they dissociate in some sort of way. So, usually, psychological trauma is one of the bigger culprits. You see here, there are some other predisposing factors that are kind of being tested or kind of in limbo right now, such as genetics. And then, of course, there are some theories that are associated with it as well. But two of the big ones are usually some sort of actual injury to the brain itself, resulting in some sort of neurodysfunction or psychological trauma. The first subgroup of dissociative disorders that we're going to talk about is dissociative amnesia. And you may recall that amnesia actually used to be grouped into the same categories with dementia and delirium, but it's actually been pulled out because it fits more here in this particular section. But overall, amnesia is just an inability to recall personal information that is too extensive to be explained by normal forgetfulness. And usually, again, the onset is followed by some sort of severe psychosocial stressor. Now, see here on this slide, I do have listed different types of dissociative amnesia, and it is very, very important for you guys to know these different types. So here you have localized, selective, generalized, and dissociative fugue. And I'm going to go through each one of these with you so that you have an adequate understanding. So let's start with generalized because it's actually the easiest one to grasp. Generalized amnesia is exactly what it sounds like. It's the inability to recall anything that has happened during the individual's entire lifetime. And this includes personal identity. So it kind of spans across the lifetime. It doesn't have a really specific theme, not really associated with one isolated event or anything. They just have chronic forgetfulness across their lifespan. Next, we'll move to localized amnesia. Localized amnesia is the inability to recall all incidents associated with a traumatic event for a specific time period following the event. The example we'll use here is a car accident. So a person they may have gotten in their car, leaving a party, get in a car accident, and they end up in a hospital. Well, with localized amnesia, the patient is not going to remember any of those events associated with this hospital visit. They're not going to remember anything prior to. They may not remember any of it. The party, the accident, the ride on the way to the hospital. All they know is that they're in the hospital and they don't know why. All right. Selective is a little different because with selective, they can recall some, but not all of the events associated with a traumatic event, same for a specific time period following the event. So if we use the same example, it would be more selective amnesia if the individual wakes up in the hospital and they remember getting in their car, but they don't remember the accident itself. They don't remember the first responders pulling them out of the car. They may not remember the ambulance ride, but they remember once they got here, people cutting off their clothes and things like that. So they remember bits and pieces. So localized, they don't remember anything associated with a particular event. Selective, they remember bits and pieces. When you get into generalized, this extends beyond a specific incident. It covers the lifespan. Next, we'll move into dissociative fugue. With dissociative fugue, the individual not only forgets their previous identity, but they usually flee from some sort of stress. So there is a sudden, unexpected travel away from home or travel away from any sort of customary activity. They kind of are wandering, and they still have some of the same things as the other ones with the inability to recall some or all of their past. And in a lot of cases with dissociative fugue, what will happen is the patient does not remember a whole lot, so they will, in some cases, assume a completely new identity. Sounds very, very similar to generalized amnesia, but the difference here is they they travel away physically away from their stress. They may end up in another city. They don't know how they got there, who they were, what they used to do, and things like that. But in a way to preserve their integrity, they usually assume a new identity and try to realign themselves with normal human function. These are a rarity. Usually, when you deal with amnesia, you're going to have one of the top three. Dissociative fugue is not anything I have seen personally. When you think of amnesia as a whole, think of certain things, certain movies that are out there, such as 50 First Dates with Adam Sandler. It's a comedy, but it gets the gist of what amnesia actually is. So next, when talking about dissociative amnesia, we're going to move on and talk about treatment. If we're dealing with something, especially where there's some sort of neuro physiological issue, a lot of the cases will resolve themselves spontaneously as one, you have removed the individual from the stressful situation, or you've given the body time to adjust or heal itself or recover from any sort of acute injury. So some cases or mild cases of amnesia, such as your localized and selective, they may resolve on their own. Cognitive therapy and individual therapy is used in order to help the client get to underlying stressful situations. And sometimes, in rare cases, they may use hypnosis. And usually, this is pharmacologically induced. And you see here the drug that they use. Um, it's a barbiturate just to kind of relax the patient and, again, help them to try to dig into their subconscious part of their brain and try to figure out what precipitating stressful event caused them to actually have amnesia in the first place. And then, of course, there's group psychotherapy. So, a lot of times, these individuals benefit from being around individuals with the same sort of issues because they feel very misunderstood. So, group therapy is very, very helpful in trying to get them to come out of their shell and decreasing some of the frustration and anxiety that they feel around this particular disorder. I mean, just imagine if you were to wake up one day and not know who you are or not recognize your family members or something like that. It can be a very traumatic experience aside from the stressful event that caused it. The amnesia itself can be a very traumatic thing to deal with. So, the next disorder that we will talk about in regards to dissociative disorders is DID, or dissociative identity disorder. This disorder is characterized by the existence of two or more personalities within a single individual. This is what you guys have come to know, or is formerly known as multiple personality disorder. A couple things that we need to talk about because multiple personality disorder has garnered a lot of attention and there's a lot of misperception with it, partly because of how it's displayed in the media or portrayed in the media. It came about initially way back in the 70s, early 60s, I want to say, when I don't know if you guys are familiar with the movie Sybil with Sally Field in it. That was the first movie that actually put multiple personality disorder on par. Since the production of that movie, which was assumed to be based off of a true story, there's some debates about whether that's the case or not, if some fluff was added to it and so on and so forth. But since the production of that movie, people took multiple personality disorder and they kind of ran with it. The truth about DID is that you don't see it that much in clinical practice. If you talk to psychiatrists, psych nurses, it's an extreme rarity. Most of your practicing clinicians in the psych world have never seen a true case of dissociative identity disorder. Some other movies that you may recognize in conjunction with multiple personality disorder or DID would be Split. Obviously, this was created to be a horror movie, so you can't take everything that happened in that movie to heart, but same kind of underlying concepts in terms of the switching between the personalities. And then if you guys ever have a chance to over your break look at Frankie and Alice, it's a really good movie with Holly Berry. It's about a lady in the 70s who experiences dissociative identity disorder. And I think that's the most accurate depiction based off the evidence that we have of exactly how that disease process actually works. So, dissociative identity disorder is when, like I said, there's a shift or existence of two or more personalities within a single individual. So you have the host individual, which is your normal client, and then they may have one to two other personalities. Usually it's two or more that you're dealing with. You have had some people come up in regards to TV shows such as Dr. Phil that have claimed to have multiple personality disorder. We get clients all the time that claim to have multiple personality disorder, but one of the things that people don't understand is that it's really an unconscious effort, this sort of thing. And we'll go through and describe the characteristics of how that disease actually is supposed to present clinically and kind of how people have misinterpreted and what you actually see in clinical practice. So the transition from one personality to another is usually very sudden, it's very dramatic, and it's always going to be precipitated by some sort of stressful event. Some terms that you may hear others use in terms of describing those personalities, you may hear them say alternate personality, sub-personality, or they just may use the word alter. This is describing the other personalities aside from the host individual. All right. With this disorder, only one personality is evident at a given time. One of those personalities is usually more dominant during the duration of the disorder, so you usually have one that's more dominant than the rest. Kind of like I'm using this as an example again. Split. I think the young boy in that movie, the young boy personality, as well as the older female, Patricia, I think her name was, ended up being the more dominant out of the two personalities, but he ended up having a ton of them towards the end that actually came that were revealed. So that's what I'm saying when I say more than one personality is there in the individual, but only one is going to be more dominant. Okay, each personality is unique and it's comprised of its own complex set of memories, behavior patterns, and social relationships. The personalities may differ in age, gender, race, etc. This goes on to include intelligence and things of that nature. There have been studies that show that even within the personalities, they may have different health issues. One may have hypertension where the other one does not. One may have vision issues where the other one does not, so on and so forth. There may be changes when you're swapping with personalities. There may be changes in the voice, facial expression, posture, intelligence. They've even shown where there have been studies where the dominant hand may change as well. What you'll find that is a defining factor of whether the client is actually experiencing true dissociative identity disorder is that a lot of times in the acute phases, this is before they've even had a chance to get to therapy and figure out that this is actually going on. The client may describe these different spurts or personality switches as gaps in their memory. They're not actually aware. It's not a conscious effort swapping between these personalities. It's not like they can just go in and grab one personality and bring them to the forefront, but they usually describe them as memory gaps or blackouts, and they can't really explain. They feel like they've lost a big chunk of time in between these personality swaps. So they really are not as aware as you would think they are about their personality changes. Treatment with this disorder is going to involve psychotherapy. One of the bigger issues that we found, or studies that we found with dissociative identity disorders, that one of the main predisposing factors is some sort of childhood trauma. So a lot of times what happens, and you'll see this in the movie Frankie and Alice if you again have a chance to watch, whatever that major traumatic event that caused them to actually propel into this disease, you'll see some symbolism in their personalities manifest as well. So anything that they've experienced in their childhood disorder, they repress that and they dissociate into these different personalities. And the client may not actually remember what actually that precipitating event was in their childhood trauma. That's the goal of treatment, is to use cognitive therapy and psychotherapy to dig deeper into their subconscious to figure out, well, what was the specific traumatic event that even caused them to be exposed to this disorder. All right. Treatment is also aimed at maximizing the function and potential of the client. The premise that has been developed based off of research is that the best goal to have with dissociative identity disorder is to successfully integrate or blend all of the personalities into one so that you have one functioning, cohesive individual. All right. And sometimes collaboration between the personalities is more realistic than integration, but overall you want them, the idea is that they never completely go away, but you want them to be able to coexist. Okay. Therapy is very, very intensive, and again, it oftentimes requires the client to recall some underlying psychological trauma, and for some, it may even be necessary for the client to re-experience that trauma. And you see this happen a lot with when they use hypnosis with these particular clients in order to actually get to the root of the problem. Like I said, if you guys ever have a chance to look at Frankie and Alice over the break with Holly Berry, it depicts everything that I've just talked about, even to the treatment phase of it. You do have some medications that are given to help with mood stabilization and depression that's associated with dissociative identity disorder. And in some cases, they've actually used electroconvulsive therapy as well. But this is basically all you need to be able to recall: how the disease presents to itself, what the underlying issue is. Um, Very important for you guys to remember that this is not a conscious effort by any means. So you're going to have to make sure that you're picking up on certain cues that are able to help you decipher whether this is the patient's doing or whether this is an actual legitimate disease process that's actually happening. The last disorder that we're going to cover in this particular category is depersonalization derealization disorder. This particular disorder is usually characterized by a temporary change in the quality of one's self-awareness, and it usually takes the form of the following listed below: feelings of unreality, changes in their body image, feeling detached from their environment, and almost feeling like they're observing themselves from outside the body, or what we know as having an out-of-body experience. So it's very, very important in order to understand this disorder, to understand the terminology and the name of the disorder. So depersonalization is when you have a disturbance in the perception of oneself. It's more internal. Derealization is when there's some sort of alteration in the perception of the environment around the individual. So you can either have depersonalization on its own, or you may have a combination of the two with this particular disorder. Symptoms of this disorder may be present in other conditions such as schizophrenia, depression, but a specific criteria allows for a diagnosis of this particular disorder. Some of the symptoms of this disorder may be accompanied by anxiety and depression for obvious reasons, fear of going insane, obsessive thoughts. They may engage in somatic complaints, and then there's usually almost always some sort of disturbance in a subjective sense of the time. In regards to treatment for this disorder, it is a rarity for it to actually happen. Like I said, usually you see certain characteristics of these things associated with other disorders like schizophrenia, but in regards to this specific disorder, it is an extreme rarity. And so the data that does exist, that is very, very limited, is it's inconclusive. So your treatments for this disorder are going to vary greatly. It's just really important for you guys to understand what depersonalization and derealization is. And I think I've explained that pretty well so far, but I highly doubt you'll actually see this in clinical practice. Next, we're going to take the nursing process and apply it to this particular category of dissociative disorders. So, in regards to assessment, you want to begin with collecting data in the following categories I have listed here. We're going to go through each one of them and talk about it a little bit. So let's start with medical workup. You may need to rule out any sort of medical or neurobiological illnesses, substance use, or the presence of any coexisting psychiatric disorders. This is the standard across the board, no matter what patient you're working with, right? Because you want to make sure that you rule out any physiological issues in order to get to the psychological stuff. Remember, we talked about in the beginning about in regards to dissociative disorders, there's usually some sort of, or one of the predisposing factors is some sort of neurophysiological component. You may also use structured personality tests and specific questionnaires to help identify certain symptomology associated with dissociative disorders, and this really would vary depending on facility. So there is no specific assessment tool or questionnaire that you would have to know for the purpose of the exam. Just know that there are some structured personality tests out there that your physician may be using in order to help peg out some of these specifics. Next, identity and memory. Of course, this is going to be important because this is the common theme where you notice some deficits with all these disorders, with this whole category. So, can the patient remember recent and past events? Is their memory complete and clear, or is it very partial or a little fuzzy? Is the patient aware of their memory gaps? Do the patient's memories place the self with the family, in a school, in an occupation? Can they remember any of those different things? Does the patient report loss of time or any blackouts? Remember, that's very specific to DID as well. Do you find yourself in places with no idea how you got there? This may be indicative of, again, dissociative identity disorder or dissociative fugue. May be an important question you may want to ask. Moving on to patient history, again, we're going to harp on making sure we address physical or physiological components before or in addition to psychological ones. So you want to make sure you ask them in their history, have they had any recent injury, particularly head injuries, concussions, or anything like that? Do they have a history of epilepsy? Or do they even have a history of early trauma, be it physical, mental, or sexual abuse? All those are very, very important. As for their mood, you want to assess for depression, anxiety, or any sort of mood swings or mood lability. Remember, when you're dealing with amnesias and things like that, it's not uncommon to see those things because the disorders themselves are very stressful to the patient, and they can be anxiety provoking, and it can cause some depression because they don't understand exactly what's happening with them. Substance abuse, I brought it up as a part of the medical workup, but you do want to understand that some of your dissociative episodes may be associated with use of a specific drug or alcohol. We've all heard of alcoholics having blackouts and things like that, so it's not uncommon for dissociative episodes to be closely related to or secondary to substance abuse. So you always want to assess that with all of your patients. Next, you want to figure out the effect on the patient and the family. A lot of times, these disorders will cause significant disruptions in an individual or within family functioning. So that's going to be something that's going to become a part of your plan of care, is helping the client to find resolution within themselves and then trying to help them repair the family structure. And then, of course, suicide risk is very, very very important. Again, a lot of these different disorders can provoke a significant amount of depression and anxiety. So you want to be on alert for any sort of expression of hopelessness, helplessness, low self-worth, or with dissociative identity disorder, you may have some of the alters displaying these behaviors that may indicate self-destructive or self-mutilating behaviors. Either way, You want to be hypervigilant with these clients and always assess for suicide risk. Some common nursing diagnoses that are related to dissociative disorders include impaired memory, powerlessness, risk for suicide, disturbed personal identity, and disturbed sensory perception. So when you're thinking about your problem list, your outcomes, your planning, it's most likely going to be geared towards these specific nursing diagnoses. So there is a couple of care plans in your book, at least one that is geared towards dissociative identity disorder, I think it is, or some sort of dissociative disorder. So just look at that and give yourself a chance to look at the interventions and things like that. But it's really similar to all the things that we've talked about thus far. So next we'll cover outcome criteria for these particular clients. By the end or of their hospitalization or by the time you finish with them, you want the patient to be able to verbalize a clear sense of personal identity. You want them to be able to report a decrease in stress. Typically, it's very helpful if you put it with a numerical scale of, I have 1 to 10 here, but 0 to 10. 0 being no stress at all, 10 being max stress level. You want the patient to be able to report comfort with their role expectations. You want to help them plan positive coping strategies for handling stressful situations. And of course, in regards to addressing suicide risk, which is of highest priority, you want to make sure that the client refrains from harming themselves or others for that matter. Your nursing care for this particular client usually mirrors the outcomes and goals that you have set forth. You want to make sure, again, that you are ensuring that the patient is safe. You want to confirm the identities and orient as needed. Encourage independence. Again, that's very, very important. Encourage expression of feelings. Remember, repression or suppression and dissociation are all defense mechanisms that the client has learned are appropriate behavior. So you want to help them relearn those strategies and encourage verbalization of feelings. And a lot of times, if you do that, it helps to alleviate stress. And then, of course, you want to use milieu therapy and psychotherapy in conjunction with all of these different things in order to care for the client in a more holistic manner. This covers all the content that I wanted you guys to know in regards to somatoform, factitious, and dissociative disorders. If you have any questions, any comments, any concerns, please refer back to page 581 in your Townsend textbook. That's chapter 29. Remember that body dysmorphia is actually in chapter 27, but utilize charts, tables, the care plans that are in there. They're very, very helpful in regards to explaining some of this information and breaking it down and helping you see it from an application perspective. If you have any other lingering questions or concerns, please do not hesitate to email me or make an appointment to stop by my office. I will see you guys after break.